Stephanie, when it comes to issues around oversedation with opioids, what kind of things are we seeing from our member organizations?
Some of the issues, Paul, that we're seeing are just prescribing practices. We may be seeing opioid-naive patients who are receiving the long-acting opioid formulations, and that shouldn't be happening. Opioid-naive patients, they haven't been taking opioids for a long enough period of time to build up a tolerance. So the long-acting or the stronger formulations are not appropriate for them. Opioid-naive patients we're also seeing where they're receiving a continuous rate of PCA, morphine, or PCA hydromorphone, and those to receive the continuous rate on those agents. That's also reserved for the opioid tolerant patients. Also, it's just sometimes it's even prescribing where patients are receiving a too high of an initial dose, and then we have patients who are receiving multiple opioids, and they're also receiving other medications which can cause sedation. So you have the additive effect between the two.
So why is this issue important?
Opioids are actually one of the most frequently reported adverse events that we see, reported to the PSO. Opioids are being used more frequently in the hospital settings, and also that carries out then to the outpatient or the community setting. So patients can also run into trouble there in the outpatient setting. And remember, opioids, they're high alert medications.
So what can our member organizations do to limit the risk around these opioids?
There's some, easy things that can be implemented. First of all, are you screening your patients to see if they're at risk for oversedation? Patients at risk for oversedation, include those with sleep apnea. Also, patients are at increased risks for sedation, generally right post-op or, new to the medication, because you're not really sure how it's going to affect them. So there's some screening tools out there that, nurses can use when they're monitoring their patients. So are the sedation scales, are they being used and implemented, and the results acted upon? Such as, if you see your patient when you go in to check on them, you can't really wake them up real easily, or they're snoring quite loudly. That could be a sign of oversedation where action may need to be taken, such as increased monitoring, decrease the dose. In some patients, they actually may need a reversal agent. Other things that can be done, it's order sets. Like I said, opioid naive, sometimes it's not recognized that a patient is opioid naive. So you can have an order set for an opioid naive and an opioid tolerant patient, just to ensure that you're starting at, what would be the recommended dose on there. And order sets, it can be either if you're still on a paper system or if you're on a computerized physician order entry. Either one can have order sets put in place. And lastly, education is a big thing. All the providers, including, physicians, pharmacists, nurses, physician's assistants, nurse practitioners, anybody who's out there prescribing, just the differences with the potency of the medications and, that sedation, occurs before respiratory distress. And then the last issue is just prescribing the proper dose.
Great. Thanks, Steph.
Thanks.